Okay, everybody, we're gonna get started again with the
Hey guys.
Ready? Sorry, that's okay.
What
Okay,
are the
so
steps to all that? Like, I'm just
hopefully
kidding.
you know where it is. But so we have a few kind of interesting lectures for the morning. First up is Dr. Chien.
Hey guys, I'm Emily. I'm one of the PGY4s. Today I'm going to go over basically everything you did and didn't want to know about heart block. But not really. The main point of this is just to get familiarized on how to look at EKGs and just recognize them. So for me, the easier way is just to kind of understand where the electrical activity is going and why it kind of depolarizes, why the conduction goes as is, and then how that correlates with the EKG, so that when you have variations or anything, you'll be able to see and understand a little bit more of what's going on. Okay. So just to go over the overview, heart blocks, basically, we're going to go over the various degrees of heart block, the bundle branches, the fascicular blocks, and then the combos of all of these blocks. So before we get started, I want to go over some of the anatomy. Just basically things you want to know. Conduction kind of goes down, SA node goes to the AV node, goes to the bundle of His, and then goes down the right and left bundle branches. And then in the left bundle branch, you have the anterior fascicular and the left posterior fascicular. And basically, the main thing that I'm just going to keep repeating is that when you have the conduction go down, it goes down and down the two bundle branches, but it usually goes from the left to the right and down into the left ventricle, which has, and then we'll go in a sort of this direction as the normal axis because the musculature in the left ventricle is a little bit bigger. So just remember, when the conduction goes down, it goes from left in the septum, it goes from left to right, and then kind of down and spreads out. Your normal axis is going to be in this area between like -30 to 90 degrees. So let's talk about the degree blocks, basically mostly centered around the AV node. I'm going to go through these pretty fast because we all kind of know it already. So first degree blocks are mainly just the prolongation of the PR interval over 200 milliseconds, which is 5 small squares. And it's really just a conduction delay from the atria and the ventricles. Causes usually are vagal tone, you're an athlete, it can be any like inferior MI or mitral valve surgery, anything that sort of knocks at the AV node, and myocarditis, hyper K, or any AV nodal blocking drugs such as beta blockers, calcium channel blockers, digoxin, amiodarone. Why do we care? We really don't. Not in ER. It's not really going to do anything. They're not going to need a pacemaker. It's pretty asymptomatic. Usually it's an incidental finding. The next one we're going to talk about is the second degree blocks. The first one is the Mobitz type 1, the wank back. Basically, this is the progressive lengthening of the PR interval until an eventual QRS drop. Usually, this is due to a reversible block at the AV node. So a malfunctioning AV nodal cells start to fatigue and then they fail to conduct. Versus type 2 is going to be an issue in the His-Purkinje system, where the QRS suddenly just fails unexpectedly. So issues or causes of this are similar: beta blockers, calcium blockers, digoxin, amiodarone, increased vagal tone, inferior MI, myocarditis, and issues with valves, so repairs. And why do we care? It's usually benign, sometimes rarely. You might need atropine, very rarely pacing, but this one and the first degree block, we generally don't do much about in the ER. Second one is the Mobitz type 2. Basically, you have a sudden drop in the QRS. The PR interval is consistent, so you don't really have a warning when your QRS is going to drop. And usually this is due for structural changes or structural damage. So anywhere from infarction, fibrosis, necrosis. It can be due from anterior MI, where you have a septal infarct, necrosing the bundle branches. And then cardiac surgeries, again, mitral valve repairs. And then as you're going to see as a theme through, anywhere from like idiopathic fibrosis, autoimmune, infiltrative diseases, hyper K, and then your drugs, your calcium channel, beta blockers, digoxin, and amiodarone. Why do we care? We care about these because they are more likely to be presented with unstable vitals, could be a sudden risk of asystole, and these need pacemaker placement. So these people should be, if they're coming in symptomatic, came in with syncope, they should be admitted and considered or get a pacemaker. Your third degree blocks are basically a complete disassociation of the atria and the ventricles. And basically you just have your PR, your P waves and your QRS marching at independent rates on themselves. And usually rhythm is maintained by junctional or ventricular escape rhythms. Causes of this, usually just progressive fatigue, AV nodals, inferior MI, septal infarcts, and then again, your idiopathic, your degenerative disease, fibrosis, issues of the heart. We care about this is because you have a risk of ventricular standstill, sudden cardiac death, and again, pacemaker. So these guys need to come into the ER, come into the hospital. So that was the easy part. I'll talk about the bundle branches next, and basically we're gonna look, so remember, so this we covered, we're gonna go to the right bundle branch and the left bundle branch. All right. So the right bundle branch, basically the EKG criteria is a QRS greater than 120, and then you have this RSR prime, a wide slurred S, and then appropriate discordance. And a way to really think about this, so remember conduction, like I said, was going to go down the septum, left to right, and then down. And a way to think about this is if you knock out the right bundle branch, you're still basically going to do the same thing. You're still going to go down, left to right, and down, except your net sort of EKG axis is going to be down here in the left, sorry, well, the right and down axis, right? So if you remember your kind of like atrial deviation, this is similar to like a right atrial deviation area. Now, if you look at the lead V1, which is sort of your precordial leads, the direction is going similar to where it's supposed to be going anyway. So think of this as like sort of you're depolarizing and you're depolarizing again. So that's why you sort of have that repeat R. That's why you have the bunny ears. That'll kind of help you remember in the V, the precordial leads. And then your lateral leads, because you're depolarizing slower, right? You knocked out one, it's going to take a little bit longer for it to look back into the same. So there's more of a slurred S coming back, and it's more, the S is the negative part. So that's why when we talk about right bundle branch, you have the M, or the bunny ears, the W, and then you're going to see in basically the appropriate discordance, meaning the ones where you have the QRS high, you're going to have a T wave or SC depression inverted, and that's normal. Why do we care? Basically, if this is a new finding, it can be signs of a occlusion, myocardial infarction. If people are getting there, they just got cath, they didn't have a right bundle branch beforehand, and then you cath them, you see one afterwards on the EKG, it's very concerning that maybe they get dissected something. So to give examples again, so on the right bundle branch, because the conduction more is like a delayed going into the right axis area, you're going to have the M, and then you're going to have that slurred S, and then you have the appropriate sort of discordance. And again, another one, you're going to have that M, so some of the slurred S and in the lateral leads, and the appropriate discordance. One last one, have a little bit of the RSR prime here, your S in the lateral leads. That's one of the discordance here. Then sometimes you'll have an incomplete right bundle branch, which is very much the same pattern, except instead of a QRS greater than 120, it's going to be less than 120. This actually is a normal variant if you see this in kids. So no clinical significance for this one. So I will move on to the left bundle branch block. Again, QRS is going to be more than 120. And basically to think about this is sort of the opposite. So remember, conduction goes down and goes from on the septum left to right and out. Now that your right bundle branch is blocked, you're now going to go kind of in the reverse direction. So you're going to go from right to left across the septum and over here to the left side of the heart. So in your precordial leads, which is B1, you're going away from it, so they're more negative. And then in your lateral leads, right, V6 and 1AVL, you're going towards it, and so it's more positive. So that's why you have more of a dominant S wave here in the precordial leads, and the broad R wave in the lateral leads. The reason why they say absent Q wave is usually when you have the conduction go from left to right, you get a little bit of Q seen in the lateral leads. Since you're going towards the lateral leads, you don't have the Q anymore. And then again, appropriate discordance in the left bundle branch blocks, you have to make sure that if you are having a STEMI that you're not missing it. There is, you do see the opposite sort of T wave appearances, but if it's very drastic, you need to apply the Scarposa criteria. So why do we care? Don't want to miss an MI. So examples of these, basically, remember, so the conduction is going down and sort of this way to the left atrial deviation sort of area. Since you're going towards the lateral leads, it's more positive in the laterals, positive, and then more negative in the precordials. You have the widening. See? And again, same, because you're going towards the right, you knocked out the right bundles, you're going more left. Your laterals is more negative. Your precordials are more positive, and then you have the widening. Got it? Yes? Too fast? Good. So next we're going to go to the fascicular blocks. So remember, in terms of anatomy, I don't remember learning about this in medical school, and I know we talk about sometimes people will throw out the word fascicular blocks. I never really understood what that meant. So anatomy-wise, the fasciculars, basically on the bundle branch, you have your anterior and your posterior fascicles. And then when they talk about this, they're talking about when one of these are blocked and what you're going to see on the EKG. So to get a better sense of it, the anterior fascicle pretty much is this thin little wire that connects over to this lateral wall of the ventricle. It's the most commonly damaged because it's supplied by the LAD. Whereas the posterior is this fan-like fascicle that sort of inserts on the endocardium of the ventricle on this bottom part. And it has dual blood supply, so the right-left circumflex, so it's less susceptible to injury. It also is less near sort of the left ventricular outflow tract, so you have less turbulence, less high pressure, so you less often see this one damaged. So before we can talk about what the anterior or posterior fascicular blocks are going to look like, we have to figure out what exactly they do. So what does the left anterior fascicle do? So remember, this left anterior fascicle basically is right here. It's this thin little wire that connects to the left side of the heart. So basically, again, remember normal conduction, you go on the septum left to right and then down. The left anterior fascicle's job is, because it connects right here on the left ventricle, it's going to start depolarizing from this part out to the epicardium and then down. So your overall vector is going to be down here. And if you remember your right axis and left axis deviation on the EKG axis, it kind of looks like a right atrial deviation. So if you were to have basically just EKG that looks like what an anterior fascicle is supposed to be doing, and you have something going in this direction, you're going to imagine all of your inferior leads are going to be positive, all your lateral leads are going to be negative. So that's what you see. All your inferior leads, sorry, I flipped it. Your inferior leads are going to be positive, lateral leads negative. So inferior leads 2, 3 AVF are positive, your lateral leads are negative. So this is what a left anterior fascicle is supposed to do, right? This is what the anterior fascicle is supposed to do. Basically, the posterior fascicle, it does the opposite. This one inserts at the endocardial, right? At the bottom of the left ventricle, it goes down into here and then out. So basically it looks like a right atrial deviation. So if you're going away from the inferior, it's going to be negative in the inferior leads and then positive in the lateral leads. So a normal posterior fascicle is supposed to look like this, right? Negative in the inferior, positive in the lateral. Negative in the inferior, positive in the lateral. So let that soak in. So that's what anterior and posterior fascicle are supposed to do. So when they're talking about a left anterior fascicular block, you're basically blocking out what the anterior fascicle was supposed to do. And the only function that you have is the posterior fascicle. So it's sort of, you have to like think about it in opposite land. Or if after you've sort of, this is too much, an easy way or trick to do is to think of sort of anterior, posterior, up and down. So they're opposite. So anterior goes with down, posterior goes with up in terms of the inferior leads. So when you're looking at the inferior leads, anterior down, your inferior leads are down first, and your lateral leads are opposite. So anterior, posterior. So anterior down, posterior up in the inferior leads. So that's why when they say in a left fascicular block, you're going to see. So if you block the anterior, you're going to be working on the posterior. Your posterior fascicle inserts here. So let me show you again. Here. Posterior fascicles insert on the sort of endocardium on the bottom. And you're going to depolarize down and up to the right. That's what your leftover fascicle is left with. So that's why they see in the EKG criteria as left atrial deviation. You're going to have in your lateral leads, you're going towards it. So your lateral leads are going to be positive with a little Q. Your inferior leads are going to be negative with a little R. And then overall, you're going to have a prolonged peak time just because the depolarization is the longer. Why do we care? The left anterior fascicular block, again, is more common just because of the blood supply. And it's commonly associated with AFib and CHF. It's not necessarily the cause of AFib and CHF. It's mainly that you see AFib and CHF have more like fibrosis associated with it. And sometimes just the overall picture of it can put them all together in one group. So I like repetition, so that's why I do this a lot. So the left anterior fascicular block, basically you knock out the anterior, you're only working on the posterior, and the general direction of the posterior is kind of going this way. So basically you're going away from the inferior leads and towards the lateral leads, away from the inferior leads, which is negative, and towards the lateral leads, which is positive. Again, different EKG. Knock out the anterior, you only have the posterior, it inserts at the bottom, and you're gonna go basically inferior and lateral. So basically the other one, when someone's talking about a left posterior fascicular block, basically you've knocked out the posterior and your only functioning is the left anterior fascicular block. So the anterior fascicular block inserts over on the left side of the heart. So it's going to go up and down, and your general net vector is going to be down here in this right atrial deviation sort of EKG axis. So if you're going towards the inferior leads, it's going to be positive. That's why you have the little QR. And if you're going away from the lateral leads, your lateral leads are more negative. Why do we care? Usually left posterior fascicular blocks are less common. You're often not going to see it in isolation. And so if you do, it's usually okay, unless you start seeing them with like chest pain, syncope, hypotension. You want to start looking out for other types of blocks like bifascicular, trifascicular blocks. Yeah, and these are usually associated with extensive cardiovascular disease, like an inferior MIs. And like all the other ones can occur with cardiomyopathies, hypertension, fibrosis, infiltrative diseases, hyper K. You might also see this in like cor pulmonale. Yeah. So here's one EKG for left posterior. Basically, you're only seeing the action of the anterior. So up, and down on the laterals. All righty. You guys still with me? So now you have your combo blocks. Basically, when people are saying the bifascicular, trifascicular blocks, basically what they mean is these are just combos. You're either gonna have bifascicular, basically you're gonna have like right bundle branch with a left anterior fascicular block, or right bundle branch with a left posterior fascicle block. That's generally what it's supposed to mean. Some people will consider a bifascicular as both the left anterior and posterior, but technically that's not what it's supposed to be. It's supposed to be right plus a left, either or. So for bicycler, like I just said, so the left anterior fascicular block, this combo is going to be the most common because it's of the blood supply. The right bundle plus the left posterior, less common. And then your causes, again, are very similar: ischemic heart disease, structural, aortic stenosis, anterior MIs, because it often infects the septum, hyper K. Why do we care? Often these may progress to complete heart blocks. It's maybe a signal for that an anterior MI has happened, and these people oftentimes need a pacemaker. So here, now that we've sort of gone through bundle branches, fasciculars, we get to see a little bit of everything. So if we look on the precordial leads, you see this little bunny ear sign, right? So you have this sign of a right bundle branch, and you have the slurred S in your laterals. And then you also see basically this sort of the negative in the inferiors and positives in the lateral leads, which is more indicative of an anterior fascicular block. And again, same thing. Your little M's, your bunny ears, your slurred S's in the laterals. Your inferiors are more negative and your laterals are more positive. This patient actually had a 99% LAD occlusion. And then one more, same thing. Bunny ears, S's, and then this is actually a posterior fascicular. So remember, posterior up in the inferior leads, so up in the inferior leads, and then down in the lateral leads. And finally, we have the trifascicular block, which is basically everything combined. Imagine as no conduction below the AV node. So you have everything. So the right bundle, you have the left anterior, you have the left posterior, and you have a third degree AV block. Sometimes you might see it as an alternating left bundle branch and right bundle branch alternating, or sometimes you might see a right bundle branch with alternating fascicular blocks. There is a misnomer. Sometimes people will call trifascicular block and consider, instead of third degree, they might consider it with like the first or second degree movements. Most common, this is supposed to be with a third degree AV block. And again, the causes very similar as the bifascicular and all the other ones: ischemic, structural, anterior MI knocks out the LAD, congenital conduction issues, hyper K, medications like digoxin. And why do we care? These people need a pacemaker. They can't go home. They have to, their heart's gonna go out, stop working. So here is an example of a trifascicular block. Here you have a little bit of a right bundle branch. Again, the M's, your S's in the lateral leads. This is a left anterior fascicular. So anterior down. These are down, and then these are up, more positive, and you have a third degree block. So basically your P's are marching on their own and your Q's are marching on their own. So this gives you sort of that full picture of all three things. And just to give you an example of the misnomer, sort of you have a bifascicular block with a first degree, you have the M, your S's are a little slurred. These are negative, so down anterior is the anterior fascicular, but then your P's and QRS's are not mismatched. That's it. We can't have a block one without the block poem.
Very nice.
Any questions?
Yeah,
Yes.
one of the best books that I have seen that explains this, one of the best books to start with, I found for interpreting electrocardiograms is the interpretation of the 12-lead electrocardiogram by Tomas Garcia. Really nice, great book, not expensive to have. You can find it online. But that I find the best book to start with. And then as you want to get more advanced, the books by Amal Matsu, which